Hello, everybody. Make sure everybody hear me, everybody see me. Any problems there? We'll get started. It's time for another class. Miranda, on that, if you'll send a private message either to me or Leland Rayford or Alex Rowe, and let us know what problem you're having with the Adobe. Just give us a heads up about that. Other than that, let's go. I know a lot of people, I see a lot of familiar names. Our classes are getting bigger and bigger from the guys who first started out with us. We're at 15 in this class. Super happy with that. We'll go ahead and give the rules out so that way everybody can get the rules. Every time we're going to roll the same rules out. I'll tell you a little bit about myself, and then we'll get started with everything, let you know how the class is going to go, and we'll go that way, that direction. So this class is being recorded for quality control. That way we can go back and kind of review it, make sure that everything's going right, make sure we're having issues. If there are issues, we can kind of correct them. We do require active participation from all students who are in attendance to this class. At any point in time, you become inactive for an extended period of time, we reserve the right to dismiss you from class, and it'll be your responsibility to reschedule before you got to restart. So just keep that in mind. Using the chat box, the polls, things like that, that's what keeps you active. I do answer questions throughout if you have a question, throw it up in the chat box. I read through there and I answer questions. Not only that, but it gives us, there's 15 other people, 15 other brains that are thinking all on the same wavelength. So it kind of gives you a lot of opinions out there. So it kind of works out well. After completion of the class, you'll be redirected back to your CE Solutions account, where you can take the quiz located on the same page as where you registered for the class. And then after completion of the quiz and evaluation of the class, you'll receive 2 hours of your credit to go towards your National Registry recert. Again, we thank you for choosing CE Solutions. There's a lot of companies out there, and we appreciate you coming to us for all your continuing education needs. Hopefully everybody's liking this. We're into 2 weeks of this now, so lots of things going on, lots of good things. Like I said, classes keep getting bigger. My name's James Schutz. I've got about 15 years in EMS so far, 5 years as a basic in the private service, and I've been with the city of Burnett for 10 years now as a paramedic. I'm currently a step-up captain as well as a senior paramedic with the city of Burnett. I've been brought on here as one of the lead faculty for CE Solutions to help kind of put this program on and instruct. I really enjoy this. This is one of the things I do like teaching is I like teaching classes. I've always taught American Heart Association classes since before I was my EMT, and I really enjoy giving the knowledge that I can. I have a lot going on. Let's see, get rid of that. All right, so this class today is the EMT Medical Module 2. We actually have 4 categories in this module just because it covers over so many topics that have to be covered in that 2-hour time period. We'll get you the infectious disease module that you have to have covered, the pain management, and then there's some synthetic herbal drug use and abuse, and then seizure management, all in this module. It's about 90 minutes of content. We'll do about 50 minutes of it. And then we'll, once we get finished with the 50 minutes, we'll take about a 10-15 minute break. We'll come back and finish it up. Go ahead and start my timer. Looks like most everybody's a basic in here. Like I said, I've got lots of experience on a transfer truck, private service. And then once I went to the city, I've got a lot of experience as a medic on a pretty busy 911 system. We were super busy over the last couple of days that we've worked, and it seems like our system, which is a small town, tends to get a lot busier. So we're going to go over the pre-hospital exposure to infectious disease. This is something that I've kind of taken the steps in being our designated infectious control officer at our department. They send me to class and they teach me things. It's kind of crazy. especially after some of the stuff I've learned through there and way that process works whenever we have a needle stick or we are transporting a patient, things like that. So I got a little insight on that side. It's kind of interesting. So our objectives for our class today is to describe the general pathophysiology for infectious disease processes, identify common infectious disease processes in a clinical presentation, and recognize the proper personal protective equipment for pre-hospital personnel, which everybody knows your PPE is very important, especially when you're carrying around sick patients. You whatever you get, whatever you're taking, whatever you're dealing with at work, you want to leave at work. You don't want to take it home with you, especially if you got little ones. So keep that in mind. That PPE is important. So let's talk about pre-hospital provider exposure. How much are we really truly putting a chance there, especially taking something home to our kids, our loved ones? The leading injury to providers is strains and sprains. We all know that because we use our backs constantly. We're constantly walking into ditches on the side of roads, things like that. So a majority of our injuries are based on some kind of strain or sprain of some kind of muscle. Our second leading injury is usually the substances such as infectious material. Being around somebody that has Hep C and need dirty needle sticks, things like that. And those are usually something we can keep from having. We just got to be a little more vigilant when we're dealing with patients with that. And even if we don't know whether they have it or not, we still got to be careful. Follow those, using the proper PPE when it's necessary. In 2013, the National Institute for Occupational Safety and Health reported that there were 20,200 injuries to EMS personnel that break down into different categories. Those categories run anywhere from exertion and bodily reaction for 6,500 injuries, which is 32%, a majority of them. Harmful exposures are 4,000 injuries, 20%. Contact with objects and equipment, 3,100 injuries, 15%. Falls, slips, trips, 2,200 injuries. And transportation incidents, where you would think that vehicle accidents, things like that would be an issue. It's only at 11%, 2,200 injuries in 2013. And violence from patients against other coworkers, things like that, 2,100 injuries. It's just 10%. So you can see where those numbers are. And that harmful exposures is 20. It's only 20%, but that 20% can last. Exertion and bodily reactions, those things you can kind of mediate those pretty quickly and move on. If it's a harmful exposure of something, say HIV, or it's a Hep B, Hep C, those kinds of things, they tend to hang out for a while. They don't like to go places, and you want to. That's where those tend to be a little more harmful. So, forms of infectious disease. What kind of forms do they come in? Well, they come into the bacteria as a single cell organism, such as strep throat or tuberculosis. TB is one that we want to be careful with when we're stuck in the back of an ambulance. Depending on the size of the ambulance, those things are really small compared to being out in the open. When you have a patient who has a known tuberculosis, you can use and I just found this out recently, was the vent system on the ambulance is like massively great compared to a lot of other places. That thing will ventilate the air almost every 2.5 minutes. It turns the air over in the back of your ambulance. I didn't even know it was that quick, but it does. It's that powerful. So viruses are smaller than bacteria, cause common cold and AIDS, require a living host to replicate. So they have to be in something living to be there. Then you have fungi. It can be a number of skin disease such as ringworm and athlete's foot. And then you have parasites that can cause sicknesses from bites such as malaria from a mosquito bite. Those things, and usually more than, we don't have too much of the malaria around here. That's usually considered a third world country kind of thing. But it does happen. There's a lot of disease-borne illnesses that are related to those mosquitoes and things like that. So how can we contact or how do we get these? How do we get these diseases on us? So there's direct contact, the process of catching an infection by coming in contact with a person or an animal that has the infection. So basically, the person who's in the back of our ambulance has the infection, and we are dealing with them, treating them, taking care of them. That's why we're at risk. When bacteria, germs, viruses pass from one person to another after an infected person coughs. And excuse me, I did not realize this, but if a person a normal person sneezes, they projectile the sneeze, the fluids, bodily fluids can be up to 3 foot away from them. As soon as I was taking a class and I learned this, and I was like, 3 foot away. Anytime anybody sneezes from now on, I am running away. I'm getting away. That's crazy. 3 foot away. And then you have those people who are super violent sneezers. Yeah. So you may want to watch out for those guys. Just saying. And you're in the back of a controlled area with it. But up to 3 foot away is how far that will go project. Yeah, it's 16 to 32 miles per hour. Yeah, I'm not quite that fast. I'm a little slow on that one. So, animal to person, so you have that possibility. You have the dogs. The dogs, when you respond to the house that bite, cats that are there, things like that. You can be infected by them scratching you and things like that. Those are harmful, as well as handling the animal waste that is there. Hopefully you're not doing that too much, but that is a possibility of some kind of getting in contact with something. Then there is the mother to unborn child. The mother may pass the infectious disease to an unborn child through the placenta. That's a possible way of carrying it on. Hence why we should make sure when we have a woman who is in labor and is going to deliver in the back of your ambulance, you have gowns and facial masks and all those things for a reason. Use them. They are there. So then you have indirect contact. Germs are passed from one person through another through an inanimate object such as a doorknob or faucet handles. A person that is infected coughs on their hands and then uses the doorknob, then spreads the germs to the surface. So basically, they go in, use the restroom, they wash their hands, and they turn around and grab a hold of the door handle, go. Or they turn the sink off with the dirty hands. Well, they've at some point in time contaminated that area and then turned around, and you go in afterwards and use them. That's how you get in contact with them. They're not there, nothing's there, but their germs are left in that one spot. My wife, on that one hand, she's complete germophobic, so she is very careful about what she does and where she does it because of the fact that she does not like germs at all. She usually will end up washing everything 6 times over just to make sure. If she comes home and she had a drilling and dealt with it, she's a paramedic as well. If she's had a patient in the back of her truck who's potentially had some kind of disease process, most of her clothes is in a bag by the time she gets to the house before it ever goes to our washer. So another way of spreading is through food and water containing the bacteria. Like I said, that is potential. More prevalent in the third world country, but we do see it here now. I mean, just like the romaine lettuce recalls, things like that. We are seeing problems. And even my favorite Bluebell ice cream, that was recalled for a problem with it. So those are possibilities of having issues with that. Just keep those things in mind. The consumption of the infected water source or food source could spread the germs to a larger number of people. When Bluebell had their big issue, they were all over Texas, and you see how quickly, especially all the fire stations, all the guys, they all like Bluebell. How quickly that could affect somebody, and it affected a large population. So our forms of transmission: droplet contact, which is droplet from when a person coughs or sneezes, 3 foot away, 16 to 32 miles an hour. Contain microorganisms that settle on an object and then transmit it to another person. Airborne transmission, when the germs are present in the air and are transmitted through the natural airways, such as TB, things like that. Keep those. That's a bad thing to get. Fecal-oral transmission, organisms are to multiply and spread through feces of a person, can spread in unsanitary conditions. and we all have those places that are, you know, the houses that we really don't like going into, but we know those are the ones who call us who really need the help, and they're not real clean. We still got to take care of them. Just keep track and keep an eye out for what's going on around you. And then there's vector-borne transmission. That's from the animals that are capable of transmitting the diseases. Um, Fleas, flies, rats, and ticks. It was rather different this morning at 2 o'clock as we're dropping off a patient in Austin, and my partner and me were headed back, and we noticed underneath the bridge where there was a bunch of homeless people, and I thought they were cats that were underneath there playing, and as we turned the corner, we realized there's a whole bunch of rats running up and down the wall. It was really weird. But that's a possibility of carrying those illnesses that, you know, and giving them, transmitting them to the homeless people that we pick up and take care of, you know, on a regular basis. And that's how they end up getting sick with something that we end up getting in contact with them. Kind of, you know, it's a circle kind of effect there. So what are some common infectious disease? Some common infectious disease and the mode of transmission. One of the biggest ones is AIDS and HIV. The relatively catching it is kind of small. Needle sticks are there, blood is splashing into mucous membranes, but a majority of the time these people, you know, they know that they have the disease, as well as the fact that, or the virus, as well as the fact that a lot of times they tell us ahead of time. I know most of them, you know, we want to make sure we're careful with the new invent of the protective needles, things like that. We've kind of made it a little safer for us to deal with this. We still have to treat these people and take care of them. We just need to be a little more protective with our use a little more PPE with them. So we have Hep A, which is a fecal oral from contaminated food, water, or close contact with an infected person. Hep B, needle sticks, blood exposure to the mucous membranes. Getting the blood on your skin is one thing, as long as it's not broken. It usually can be washed off, disinfected with some antibacterial soaps, things like that. It's where you have, when you puncture the skin or break the skin, or you have the mucous membranes, that's where you can get the issue. I encourage everybody, the Hep B series helps keep that from affecting you. I encourage anybody and everybody who's working in the EMS and medical field that Hep B series. Yes, it's a pain. It's 3 shots to get it done, but it's important because it prevents you from catching something and taking it home to your family. We, as a department where I'm from here in Burnet, we take care of all of our employees, make sure they're all up to date on their and make sure they have their Hep B series, and we offer the shots to our guys. How many of y'all out there actually get some of these vaccinations from your work when you hire on new guys, things like that? It's one of those added benefits. Yeah, exactly. Yeah. Some do, some don't. And if you don't get it from your work, I would encourage you to see your healthcare provider, your doctor, your physician, and say, hey, this is what I'm doing. I know that it's kind of slow, you know, slow. There's not much of a possibility, but it's better to go ahead and get it. We offer the flu shots, our Hep B's, our tetanus, things like that to all of our guys. And that's just an added benefit. For one, if they come to our department, we keep track of their records for them, keep them up to date. And two, they turn around and, you know, they don't have to go make a doctor's appointment for it. You don't have to go in and see your physician, pay the extra $10 for the flu shot every year. Here in Burnet, we actually cover the whole city. We make sure everybody in the city has the ability to get their flu shot. Keep everybody at least somewhat better during the flu time. Is there a database that'll tell us hands-on that this some type of HIPAA violation? Yeah, that's the problem, is you can't violate HIPAA with it, so you can't really, there's not really a database that's going to tell you who's infected with these things. It really has to be, you have to be in contact with them to find these things out. And a lot of times I've found out with my patients, they may not tell me about it. Now, if I get a nurse to nurse on a transfer, something like that, then they're gonna give me a heads up about it, or it's in their paperwork. But it's not something that you go and look on a big database to where we can type in their name and say, hey, do they have any infectious disease? They just don't keep track of that because of the HIPAA violations. So it's kind of, make sure a lot of times the nurses know to pass that information on. Last night, one of the patients we had taken in, all the nurses were going into the room and they had masks on. And I said, is there something we should have known? I've just rode an hour in the back of an ambulance with this gentleman. And they said, no, we just do this with, for certain things. And he's not, it's a possibility. Well, the possibilities were really not there for us by way of the ambulance. So it wasn't a big issue, but it's good to know those things. And if you have a good working relationship with your nurses at the hospitals you're picking up from, they'll usually tell you ahead of time, hey, this guy has this or this guy has this, so be careful because of this. But there's not a real database for anything like that. Hep C, contracted by blood, contaminated with the virus. That Hep C stuff is really nasty stuff. You've got to be careful with that. It's a long-term type disease. Very detrimental. Then you have the influenza, the flu. Every year it changes. Sometimes the flu virus works, sometimes it doesn't. Just depends on whether they catch the right strain that time in that year. So far, I've taken the flu shot the past 2 or 3 years, and it's really done good for me. This last year was probably the most painful year that they put. I got shot in the arm, and I had never had the pain in the arm like I did this year. So it was a little different mix for what they gave this year, it seemed. It had a lot of people respond that way as I was giving up shots. My arm hurts a little bit more sore than what it normally is. Everybody did get their flu shot this year, right? Oh. We still had guys turn it down and say, yeah, no, I don't want it, and you have that right to turn it down, but when you're working with sick people, you want to make sure you're taking care of yourself, just to make sure. Yeah, the flu, yellow fever, rabies vaccine doesn't even sound fun. Not at all. So there's some other common infectious diseases, the meningitis, bacterial, meningitis, viral. Those are common that you can get. They have a vaccine now for some of them. Tuberculosis that's airborne. In the back of your ambulance, you're closed in. If you got somebody who's got that, I encourage you, if you got somebody who's got any kind of airborne coughing, sneezing, thing like that that's going on, cut on that vent and let that vent circulate the air in your, it pulls that outside air in. I actually had one that was doing quite a bit of coughing the other day, and I opened up a window and it pulled air from the window. I could actually feel the air pulling through the window as it was being pulled in by the vent. Pneumonia, airborne. It's inhalation of the virus or bacteria, depending on which it is, and it's usually spread by coughing and sneezing and spreading through the blood contact. Sometimes pneumonia is a bad one because usually, we carry a lot of patients who have pneumonia, especially during this time of year when they get sick. There's Ebola, which spreads through direct contact of infected or sick person's body fluids. It's kind of, that's one of those ones that are really not common, but they do occur, and they do have some, it does happen in the States. It's few and far between, but it happens. So let's not discount them just because, I've heard about it before, that's somewhere else. We can't discount them because, there's a possibility. That's one of the big things that wasn't long ago that every time you went into the doctor, you go in and they ask you, have you ever been outside the country? Have you been outside the country within the last 2 years or 90 days? Things like that. There's a reason why. It's because there's potential of bringing things back in when you've been out of the country. Yeah, and if that's who your people are. That's kind of, know the people that you're dealing with. There are parts of our area that are not really, most glamorous part, and we know to be careful of those people. So the personal protective equipment. This is really, truly, and very important for us. Selecting the right equipment for the job is vital to prevention of the infectious disease. Gloves should be utilized on every incident, but should not be your only source of protection. The level of PPE should be used depends on the task at hand. OSHA requires that the employer to provide the proper PPE and to ensure that it is cleaned, laundered, and disposed of properly. That's that's OSHA's only requirement, is to make sure you have it and make sure it's cleaned, make sure it's taken care of. The biggest thing is you making the decision as a provider of what's best for this patient. I rarely ever do I walk into a scene without gloves on. That's a standard for me to get out of the truck with gloves on. It's a standard if it's somebody who's, I'm going to have to do an intubation, we're going to have something over top of my eyes and over my face, things like that. Choosing that level that's appropriate for what you're doing. If you have somebody, wasn't too long ago, when we were dealing with the patients that had the flu, where we were sealing off the ambulances and everything else, and you were almost in like a Mach 3 suit and everything else, I mean, you got to use the proper level of PPE depending on what you're dealing with. It was quite interesting during that period of time because I'd never seen us seal off an ambulance the way we had. We had protocols for it, protocols for who were doing what and where they were going, and what you did afterwards that had never been there. And 9 years before that, we had never had established anything. Didn't have a reason to. And now we had all these extra stuff, and we had an ambulance that was designated to where if this come out and this patient sounded like this and dispatched, then we responded with this ambulance for this reason. Can't remember what the name of that was, but it was really sick. Does anybody remember what it was? It was a real bad out then. So I'm going to throw another poll out there. Let's see. I got a couple of them. I made up some new ones today. Let's see. There we go. How about that? Yeah. So how often are you required to do an infectious disease class? I just want to see what everybody's opinion on is. What do you think? How often do you think you should have to do one? So safe use of the PPE. Always keep gloved hands away from your face and limit touching of surfaces with contaminated gloves. Providers should know how to properly don and doff all PPE. Doffing should be done slowly and smoothly to reduce the risk of self-contamination. If a patient is highly contagious, hands should be washed and a new pair of gloves placed, then remove gown. The last should be mask or respirator prior to clean glove removal. With the safe use of PPE, I guess one of my biggest pet peeves on an ambulance is whenever I go to get back in the front of the truck after we've dropped off the patient, the back's cleaned up, and I find a dirty pair of gloves sitting in the front of the ambulance. To me, that is my clean area. And it's not, and we all know it's not clean up there for sure. But that's the clean area, and we want none of that stuff in there. So a lot of my guys who I work with, they know, hey, as soon as I get finished messing with this patient, before we hop up front to drive to the hospital, they take their gloves off, throw them in the trash, and then we're off. And that's important. Those areas, and when it's time, the once a week or whatever that you clean your ambulance or after every major call, there's certain areas of the ambulance that usually don't get cleaned and we forget about them. Yeah, exactly, Will. So mine is when the driver drives with the gloves on, you're touching a steering wheel that just touched a patient. You're just carrying it over to the steering wheel, and you don't come back and wipe the steering wheel down every time. I mean, come on. Well, keep that area clean. The front of the ambulance is a clean area. I don't have too many pet peeves on an ambulance. I've been doing this long enough, and I'm pretty easy to get with everything on that. But they all know Schutz doesn't like having a lot of dirty gloves up in the front of the ambulance. That usually gets me ticked off pretty good first thing in the morning. But making sure that we clean those areas. That bar that everybody grabs a hold of, it's hanging up on the top. A lot of times people don't realize that when you inadvertently, you're so used to standing up, you may have blood on your hands. You grab a hold of it and you slide. You're moving your hand. You're trying to keep yourself standing up. That thing, it gets blood on it and germs on it like crazy. So make sure we're cleaning our trucks. Cleaning those spots, those areas that you don't normally think of. So yes, going back to the poll, most everybody was correct. The every year is usually when you're going to do that infectious control class. They just bring you up to speed, remind you who the designated infectious control officer is, what procedures and policies you have to follow if something happens and you do get a stick, things like that, and what to do and how you're going to take care of yourself. So how do we get rid of our contaminated PPE? After wearing PPE, we dispose of all contaminated equipment. We get rid of it. Reusable equipment should be decontaminated before being placed back in service. Our laryngeal scope blades are still the old metal blades, and we end up bleaching them. They'll soak in bleach and get taken care of, and then turn around and they'll come back and they'll get taken. We'll get, after sitting there bleached for a while, we'll put them back in service, but not before then. We don't use it again. It gets taken out of service. Like I said, make sure your ambulance is properly decontaminated. They have those wipes out that are super nice now, make it real easy. Things like that. And then you bleach water and Lysol. It's always fun. When you got clean ambulances when you open up the door and you can smell the Lysol still hanging out in the air. That's somebody's taking the Lysol to maybe an extreme then. But a study shows that in several Chicago area ambulances tested positive for staff after being clean. These things are things, that's even after they're, clean. So keep that in mind. These are diseases and viruses that are possible to transmit to you when you're just doing your job, and that's time off, things like that. You don't want all that. We all enjoy our jobs for sure, and like going to work. When you're sick at home and you've got something that's hard to get rid of, that's not no fun. So proper disposal and decontamination of equipment and supplies is required to prevent cross-contamination, especially if we're using it for, you have your stretcher, you get 5 or 6 patients on there a day. You don't want them cross-contaminating things to each other, less likely to you. Make sure we're cleaning up stuff. It's one of our, we all say work on the ambulance, I'll save lives. No, not really. We're more into janitorial work and cleaning, and I'm really good at mopping floors and washing trucks, things like that. That's the important stuff that we do in between the calls to make sure that our next call is going to be good. So cleaning and disinfection is a 2-step process. You have cleaning, the physical process of removing materials such as blood, body fluids, and foreign or organic materials from objectives. Then you have disinfection, the process of killing off and preventing the growth of germs of organs or objects on the surface. So we may wipe it down to kind of clean off all the stuff there, and then we spray something on it to completely disinfect it and get rid of all the nasties that are there. Get rid of all the germs that we can't see, all the stuff that doesn't see. Usually a lot of times when we use the disinfectant, we'll spray on it and leave it on there for a certain period of time to give it time to kill those germs off. Standard bleach mixture at a ratio of 1 part bleach to 10 parts water should be used for disinfecting most objects and surface. That is if you don't have the wipes that they've come out with, those chem wipes that they use. A lot of the hospitals, our hospitals, provide them for us for the most part. They let us take a can of them for each of our trucks every time we run out. They just throw us another one just so we can keep our surfaces clean. It's what's best for the patients. It's quite interesting that over the period of time, I've noticed with delivering patients to a hospital that patients now, when they're delivered to the hospital, one of the first things they do is wipe them down with disinfectant wipes to completely head to toe, because they're trying to decrease the infection rate that's involved at the hospital. So if they're doing it at hospital, we need to follow suit. Maybe not having to wipe the patient down, but we need to be moving them to a clean stretcher with clean sheets, clean pillowcases, and a clean environment. Anything that's going to help keep the infection process or starting the infection process. We as providers should be doing the same thing. So with the conclusion of the infectious disease, with the use of proper PPE, you can minimize your exposure to infectious disease. And like I said, a majority of the time that exposure is very limited already to start with. Using the proper PPE, we can almost completely eliminate it out of a possibility for you. But if you are exposed, follow your local policies and wash all the exposed areas. Find out who in your department is your designated infectious control officer. Find out the policy on what you do if you get a needle stick, if you have a dirty needle stick or whatever, if you come in contact with this person. We had a patient who had a viral, I want to say viral meningitis, and we actually had two of our guys who were quarantined to one of our stations, could not leave, nobody could enter, nobody could leave for, I want to say it was 72 hours straight. They were stuck there. We had to deliver food, things like that to them, just because of the fact that they were in vicinity and transported a patient who was really sick. Keep these things in mind. Cleaning and disinfecting is key to preventing the cross-contamination. If you have the spare time, usually a majority of the time as a medic, while I'm in taking care of my patient report, taking care of my passing on the report to the nurses in the ER, things like that, the basic, using my partner, he's out there cleaning the truck and making sure it's ready for the next call. He wipes everything down, make sure all leads, blood pressure cuff, anything that made contact with that patient is usually wiped down pretty good before he puts it away and prepares it for the next call. Anybody got any questions or input on the disease infectious control or anything like that? Everybody still with me? Am I going too fast? We got about another 20 minutes here, and we'll knock this section out, and then we'll take a quick break. Yeah. So we're going over the pre-hospital pain management. Pain management is become more and more useful in the pre-hospital care. At one point in time, it was don't give pain medicine to nobody. And it's, now it's kind of come around to where we realize that there's a lot of things that when a person's in pain, there's a lot of other associated effects to the body because of it. And as that happens, we kind of have decided as a first response EMS providers that us kind of taking care of that pain initially before we get them to the hospital is usually better off for them, better for the patient. So our objectives for this part of this section of class are as explain the nature of pain and its definition, characteristics, types, and source. Identify methods of assessing pain in children and adults using available assessment tools. Discuss common pre-hospital pharmaceutical and alternative non-pharmaceutical interventions for pain. List indications and contraindications for pain in the pre-hospital environment. I will say some of this slideshow is also used in the advanced stuff, so we will be going over a little bit of advanced stuff. Don't worry about it. I don't believe any of it will be tested at the advanced level just because of the class it is. I think it's all good information that's here on pain management. Like I said, it's a growing concern as a provider to make sure that our patients aren't in pain, and I see a lot more people using it a lot more effectively. So pain is the most frequent complaint for people seeking emergency medical services. That's your first line of knowing when there's a problem. I'm in pain, whether it be chest pain, or you have head pain, you have headache from possibility of blood pressure being high, or stroke, hemorrhagic stroke. There's a pain is associated. It's your body's way of telling you that there's a problem. And a lot of times that's what we get initially on our first call out there is I have pain. Annually, 17.4 million doctor's visits are as a result of pain. Just keep that in mind. They're showing you that the numbers are up there. In 2003, the National Association of EMS Physicians stated that the relief of pain and suffering of patients must be a priority for every emergency services system. The reason why is because of the fact that there's so many effects that are taken on your heart rate increases, your blood pressure increases, your catecholamine release causes all these things to take place. Relieving pain relieves a lot of that. Not only that, but it becomes comfort for the patient. So you can see why this is important for us to take care of this initially when we first start out with this patient. So nature of pain. Pain is an important physiological protective function defined by the International Association for the Study of Pain as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. Basically, we lay our hands on top of the stove that's hot. Pain tells us, hey, you're burning your skin, you're causing an infection, you're having damage to the tissue, remove your hand. That's what our brain is learning. Or, just think about it. Our brain is saying, okay, I have pain, I don't like that, I'm getting away from it. Same thing with everything else. With pain, when pain takes place, it tells us that this is a bad event, we need to stop doing what we're doing. Does that make sense? The physiology of pain is sensation of pain is caused by electrochemicals, nerve impulses delivered from the sensory receptors called neuroceptors. The receptors have a higher threshold for activity, some of them do, than the rest of the system. So basically you can, you have pain, you can take pressure up until a certain point, and then all of a sudden pain hits. That's the same. That's what's basically saying. You can handle the pressure of something, and I can handle it up until a point where it becomes painful. That increased stimulation increases the impulses increased, resulting in the feel of pain. So that's how it actually works. So as that starts, so you have, think of it as pressure. The pressure starts as pressure is taking place and it's squeezing. You feel, yeah, I feel pressure. Then all of a sudden, as those receptors continue and the impulse increases, then you start to begin to feel the pain. At that point in time, your body says, okay, I'm going to get away from this and move forward. So there's three types of pain that we deal with. There's somatic pain, which is activated by receptors in the body's surface or musculoskeletal tissue, common in surgical incisions and traumatic injuries to limbs, broken arms, things like that. Those things that are things that we can usually tell, yeah, that's kind of broke. It's going to cause you some pain. It causes me pain from looking at it. Just think of it that way. Then you have visceral pain, activated by receptors in the body's organs that are enclosed within the cavity. These are commonly found in chest pain and abdominal pain. That's the visceral pain. When they've got the belly that's hurting, or they have the crushing chest pain, that's usually associated with cardiac events. It's what we start with, and what we worry about most when they have chest pain, right, is the cardiac events. So that's what visceral pain is. Then you have neuropathic pain, malfunctioning of the peripheral nerves or spinal cord. Patients who complain of a burning or tingling or soothing pain. This is like sciatic type pain, or even the pain in their feet when they've been a diabetic for years. They start to feel that tingling and that burning. I forget the words right there at the tip of my tongue. Can't think of it. Somebody chime in. I know somebody knows it. But the neuropathy that's taking place, that's the tingling and burning sensations that they're getting. That's a neuropathic pain. Everybody still with me? Let's see. Then we have acute versus chronic pain. Acute pain is something that's happening right now. Starts all of a sudden. Is often has some kind of reason why. Pain that may last a little while until the wound heals and then goes away. Some conditions such as migraine headaches can cause acute recurring pain. You may have migraine headaches. I've never really had migraine headaches, but I do know a lot of people who do. What's the difference, especially in pain, is running down to your fingers? That's one of those, the pain that's running down the nerves. I would say normally if it's something that's traveling and you have pain that's running, kind of like sciatica, it's a nerve damage of some sort that's taking place. That's something you for sure they're going to want to be seen by somebody who's a neurologist of some sort. I hope that answered your question. An axolotl of some sort. Yeah, that's exactly right. But then you have, in some conditions such as migraine headaches can cause the recurring pain. ultimately, usually the acute pain is going to go away at some point in time. That's okay. I broke my arm. Once the arm heals, the pain goes away. We don't have it no more. Chronic pain is somebody who's got an injury that's lasted for months or even years, even after the wound has been healed. You have people who have chronic back pain. They usually have some kind of something, something happened to their back to where even after it's healed, they still have that pain there. Um, that would be considered chronic pain. Frequently associated with neuropathic conditions such as fibromyalgia. That's probably the number one thing that they've called for chronic pain. That is what fibromyalgia is chronic pain. Uh, is when they can't find what's causing it. It's usually where they go with it. Then you have musculoskeletal pain. Traumatic injuries occur when the body's tissues are exposed to forces with greater energy than they are able to absorb. Traumatic pain, for sure. There's two categories. There's blunt and there's penetrating. Blunt is a result of falls, motor vehicle collisions, blunt objects, things like that. Penetrating is when the body is pierced by foreign objects. Usually the pain is a little different that way. Burns cause pain as well. Exposing the tissue to heat can cause pain. Just like I said, putting your hand on the stove gets hot or it's hot and you say, hey, get away. Pulls away. Depending on the burn, depends on the depth of the burn, depends on how much pain there is. In full thickness burns, patients only feel numb due to the fact that the nerve damage, the endings of the nerves there are completely burned off. Around that area is normally going to be a little more painful. And then anything a little further out from the center of that area is going to be a lot painful. See, Hannah said if you dislocate something and it is dislocated a lot after that is chronic pain. Well, that is chronic pain or acute pain because the pain happens with the dislocation, but it's it's a chronic problem. I would say that if it's pain only whenever it's being dislocated, that would be an acute pain. Usually you don't say a chronic pain is associated with a dislocation unless it happens on that time. If it happens daily, yes. And usually at that point in time, that person needs to see the physician to find out what's causing that dislocation. Either there's some torn tendons, things like that, or there's stretched tendons, things like that. That would need to be seen by a physician to where they are able to kind of look at that and see how they can prevent it. And maybe it's just a matter of fact of going in there and fixing that tendon, and we'll get rid of, and we'll alleviate that pain. So there's cardiothoracic pain, chest pain. We all run the calls with chest pain. Yep, loose tendons around the joint capsules, allowing that movement to take place. That's exactly right. And usually those tendons can be fixed up and taken care of and made to where they're tightened up so we don't have that problem no more. Chest pain is the most common complaint of patients who request EMS. I am a huge advocate of if you have chest pain, call me. I don't mind coming to visit you at 2 o'clock in the morning, whether your chest pain is something that is just normal or something that is something that's acute. My biggest issue is those that don't call us and we end up turning around and working them 2 hours later because they didn't call us and it's something we could have helped prevent in the act of having chest pain that was a STEMI or a heart attack. We treat it aggressively in EMS due to the fact of it possibly being a heart attack. We use oxygen, aspirin, nitrogen, and morphine for the ALS providers. It should give you an idea of whenever you're in EMT basic and your first three drugs that we list there, oxygen, aspirin, and nitro, why is it so important for an EMT basic to be able to give those drugs? Because chest pain is that important. It's something we need to get rid of. Even if the fact that they're not having the heart attack and you're not able to read the 12 lead, things like that, the ability to get rid of that chest pain on your way to the hospital is important. It's often related to decreased perfusion of the heart muscle that's there. The heart's saying, hey, I'm not getting oxygen anymore. I need help. And it wants to know those things. So, it makes a difference. Pain is also can also be from pericarditis, which is inflammation of the pericardium, which is around the sac around the heart. That eventually will cause an occlusion. It will prevent the heart from actually, being able to pump blood like it should. So those are important. Patient may also experience pain with blunt thoracic trauma, chest getting hit in the chest, things like that. Usually, there's an event associated with that. If they're calling you because they have pain, chest pain, or tightness in the chest, it's always perceived cardiac until we can prevent. We can uh, before we can do anything. Let's see, we live and die with oxygen. Yep, well, I can almost say that. I don't know about the O2 or die, but without it, we're going to die for sure. Pulmonary chest pain. That's the exacerbation of COPD that causes chest pain where they've been coughing for long periods of time. This pain is described as tightness, swelling within the lower airways, and a decreased oxygen exchange within the alveoli. This pain is relieved with oxygen bronchodilators. Because they're so tight, they start to have the chest pain, tightness, and things like that. Giving them the bronchodilators, the oxygen, relaxes those muscles and allows that to start getting oxygen back to it. The pulmonary embolism causes a sharp pain reproducible with movement and deep breathing. So keep those things in mind. If they're complaining chest pain, having trouble breathing, and they're able to take a deep breath and cause it, and they move this way, I feel the pain. You'll be able to kind of see what the difference is between the pain that's there. Abdominal pain. Gastritis is a cause of abdominal pain. It's inflammation, disease of the stomach that causes burning pain in the epigastric region. Usually it's up high underneath the ribs. That's where you have those issues. You have pancreatitis, which is inflammation of the pancreas. It will result in severe epigastric pain radiating into the back. A lot of times anything in the abdomen that's going to have pain is going to radiate the pain somewhere else. Some of the worst pain I've ever had in my entire life was from my gallbladder, from cholecystitis. I had pain that started out in the abdomen, went up into my shoulder blades in the back, and it felt like every time I stretched, if I stretched that scapular area, it would be okay. Initially, when we went into the hospital with this, they told me, "Oh, you're having anxiety," and that's what I thought it was. After doing an ultrasound, they said, "No, you've got huge stones in your gallbladder. We need to take that out." Scheduled this, of all things, scheduled the gallbladder surgery on my birthday. Took it out and have yet to have the pain again. That is the worst pain ever. And just knowing that, and a lot of my patients, when they have this, and I say, so you have this pain and it goes up into the scapular region, I'm like, does it change when you feel like you're stretching? Yeah, it kind of goes away. It relieves it a little bit. Okay, kind of gives me an idea where we're at. Additional abdominal pains that are important are the appendicitis. The infection with the appendix causes pain in the right lower quadrant with rebound tenderness upon palpation. A lot of times, these people will be able to pinpoint where your pain is. My son at the time was 7 years old. He's 21 now. 7 years old, was able to say he had real bad pain in his abdomen one morning. And I asked him, I said, "Where are you hurting at?" And he pointed straight there to where his abdomen was, right there where his appendix was. Took him in, and sure enough, his appendix was inflamed. He had surgery that afternoon to remove it at 7 years old. Because the pain told him there was a problem. Never had pain before that. Diverticulitis is a very painful thing because it's when the diverticuli become inflamed. It causes a general pain that eventually increases in the left lower quadrant pain. So that left lower quadrant becomes painful. My fiance has kidney stones and she almost passes out from them. Yes, kidney stones are pretty bad as well. I know several people who have them. Those crystals being passed and moving throughout the uterus are horrible pains. They're sharp pieces of crystal. Doesn't say I've never had a kidney stone, and knock on wood, I hope to never have one, just because I've transferred so many people with it. Because of the pain that's associated. You may not take them because of the actual kidney stone. You're transporting them for pain management. Just keep that in mind. The abdominal aortic aneurysm is when you have that tearing sensation. It's actually a blood vessel that's tearing. There was a call not too long ago that my wife ran or she wasn't on, she had heard about where somebody had recently had that one of those AAAs, and they took him to a local hospital. It ended up being emergency transport because he was dissecting. It was actually tearing open. And wouldn't you know it right now, they don't have no helicopters that'll fly because of the weather. So you transport that 45 minutes by ground in an ambulance. You're sweating in the back of the truck. I promise you, you're sweating with that patient. You're worried about that thing completely. You know, as soon as it dissects, they're going to bleed out. It's not a good outcome. Headaches. You have I know we said 50 minutes. Let me go just a little bit longer here. We're going to finish up this section, and we'll take a quick break. I got about 4 more slides, okay, guys? We'll take a quick 10-minute break at that time and jump back into it. Subarachnoid hemorrhages. We got bleeds within a brain tissue caused by vessel leakage. Sudden onset, worst headache ever. These are those strokes, those hemorrhagic strokes that are life-threatening. We've got to get these people taken care of. They'd be perfectly fine and say that's the worst headache I've ever had, and their blood pressure usually associated with that is super high. That becomes a thing where we need to find a stroke center that has a vascular capabilities as well. Keep those things in mind. You can only have so much blood, so that your brain, your skull is a 5-gallon bucket. You can only have 5 gallons of material in there. You put extra blood in there, it's not a good place for it to be. Hypertensive encephalopathy. Edema caused by fluid in the brain causes increased pressure in the cranium. Patients will increase with significant hypertension. Therefore, you see additional fluids inside the cranium creates a problem. And that's your first thing, is that pressure as well as the pain. The body's telling you something's wrong. We need to be fixed. Meningitis is a viral or bacterial infection of the meninges. They become inflamed, and that causes pain as well as stiff neck and fever. Look for the connection between so you've had a headache for several days, and you can't turn your head from side to side. You have a problem. You need to be looking at that infectious control. Back to the infectious control issues, and making sure you're gowned up and things like that. You don't want to catch what they have. A lot of times this is a fever associated with this as well. Look at the full picture. Look at the big story. Everything around this patient as you're doing your assessment of them, and get the full picture of them. Not all pain is associated with an elevated heart rate, blood pressure, or elevated respiratory rate. A lot of it is because that's part of what the body is. Now, if they're on medications that prevents that from happening, then you know. So there's 2 different ways to scale it. There's the numerical rating scale. We all use that, or there's a verbal rating scale. So we use the numerical is 0 to 10. What's 0 being no pain? Make sure you specify that. And 10 being the worst pain you've ever had, you can ever think of. Have them put a number to it. Because that makes a difference. They got to know that 0 is no pain at all. Normal every day. And know what their baseline is. It said normally I have pain in my knee on a regular basis, but today, normally it's about a 3. Today it's a 15, because this is the worst it's ever been. So that's why we're taking you, is because you have knee pain. Then there is the verbal rating scale, which is described as pains with adjuncts such as none, slight, moderate, severe, or agonizing. I don't use that one near as much as I use the 0 to 10. The 0 to 10 is quick and easy. They understand it pretty well because they're used to using that in the hospital. But that same, the verbal rating scale, they use it in the hospital as well. So treatments for this. As providing compassion, comforting words is proven to assist in the relief of fear and anxiety and compound distress of painful injuries. Those things are important. Being able to comfort the person can relieve some of that pain. Treat fractures with splinting, immobilization, and application of ice packs for fractures. Positioning a patient in comfort can assist with relief of the pain. These are non-pharmaceutical ways to help, if it feels better for them to have their knees pulled up into their chest, and that's the only way you can get them on your stretcher, strap them down like that and get them to the hospital, especially if you don't have the ability to give any pain meds. Here's some of those pharmaceutical pain reliefs. A lot of these are going to be the ones that are ALS, basically. A lot of places don't have the basics, or EMTs give these things. It just depends on your protocols. We got morphine, which is a CNS depressant. It's got a rapid onset and it lasts about 2 to 7 hours. Fentanyl is a synthetic opioid. It's 100 times more potent than morphine. Works great. It works within 90 seconds, but it doesn't last near as long. Doesn't have some of the same effects as morphine either. Toradol is one that's a non-narcotic NSAID that they give at the ER. A lot of ambulances and services aren't carrying this one. It usually takes 10 minutes to go in effect, but it lasts 2 to 6 hours. Ketamine is new to the EMS usage. For pain, we use it and burn it for pain. We just actually started using it for pain before we ever used it for sedation. It works great for pain management. We've used it multiple times, have people who have limbs that are fractured, that are out of whack, and we can give them that. They no pain at all at that point in time. We can reposition the fracture and get them splinted and get them to the hospital, and they are usually very thankful. Indications and contraindications. Pain is associated with increased anxiety and has a negative impact on immune function and wound healing. So there are limited... You want to limit what we're doing by way of, we want to get rid of our pain as quickly as possible. That's why it's important. Paramedics have standing orders for pain medication, tend to administer more of them effectively. If you have standing orders, you don't have to call the hospital for them. Use the standing orders. Do what you need to do and put that patient at a point of comfort. Absolute contraindications for pain management is hemodynamically unstable. The blood pressure's got to match or get within the limits. Respiratory depression, because a lot of the opioids that we give will cause respiratory decrease in respiratory rates. If they're already depressed, we're going to depress them more. It makes it difficult for us. Alter mental status, you're going to make them more altered as soon as you give them those medications. Labor and pregnancy, a lot of the pain meds we carry are going to carry over to the fetus, so keep those things in mind. And allergic reactions to medications, a lot of people are allergic to those. Patients with pain is relative to the patient, does not always increase with vital signs. Just remember, if they say they're in pain, treat them as if they're in pain. It's probably the best bet. Management of pain early in pre-hospital settings is beneficial to the patient's immune system and overall healing process. If we can get them out of pain, they're better off. They're going to heal. They're going to be calmer. They're going to be easier to deal with than back to the ambulance. Pain management relieves the anxiety and emotional damage that can result from an injury, especially in children. Kids see their arm being all mangled. That's painful to them, and it kind of bothers them. That relieving that pain, give them especially ketamine. When they go on that ketamine, they don't even realize what they're in pain from, and they're really not in pain at all. Super crazy. It's a really good medication we use. So with that, we are going on to the next section. We're going to take a quick break. Let's come back at 3:03 here my time. Let's come back and give me, say, 10 minutes. We'll come back at 3:13. 3:13 sounds good. 3:15. Come back at 3:15. I'll give you 12 minutes. I'll pause everything. I will be paying attention to the chat room. If you got any questions, if I'm moving too fast, I'm just trying to get those last few slides out. Last few questions in the chat box. A quick little break. We'll get back into things here. We're about halfway through. We've gotten through 2 sections of this module, EMT Module 2, Medical Module 2. A little ranting and raving about looks like the Saints fans out there, the Patriots fans out there. Yeah, I grew up in Texas, and I'm a huge Green Bay Packers fan. I don't know why. It's crazy. I wear my Green Bay Packers stuff everywhere. So we're going to go over synthetic and herbal drug use and abuse. Oh, it's one thing the Cowboys fans are, is they're very loyal, no matter what. So our objectives are: identify common synthetic and herbal drugs of abuse, discuss pre-hospital treatment of patients under the influence of synthetic or herbal drugs. These tend to be more prevalent nowadays than they've ever been in the past, to where we didn't, they weren't there. They weren't there. You didn't have all the synthetic type drugs, and they're more risk for us as EMS providers because of these side effects for them. I think I got a poll. We're gonna throw up a new poll real quick since we're done with the break. Let's see. In this poll, looks like most everybody was right on that one. Let's see. Real quick. Let's see. How many years of, hold on. Whoa. All right. Now answer it. How many years of experience do you have? See what everybody in the room has. Some of y'all have a lot, and some of you have very few, a few years. So drugs of abuse are chemicals taken in the body for medicinal reasons with the intent of creating mind and mood altering changes. Commonly abused drugs are heroin and other opiates, cocaine, ecstasy, LSD, marijuana, and prescription medications. Just a precursor is I'm not here to discuss whether it's right, wrong, indifferent. It's by government standards. They're illegal at this point in time, so all of those are listed were illegal, and we'll leave it at that. So herbal drugs are from plants or with hallucinogenic or psychedelic properties. Herbal drugs are spread across the globe, often carried by refugees who consider these uses cultural, common, and less harmful than drinking alcoholic beverages. Some people, it's in their culture to use these drugs. They were used by Indians way before we were ever here. So just keep those things, and they're out there, and they're still being used by a lot of those people. Most are considered illegal in the United States. For the most part, if the United States government sees them as being a threat of some sort or harmful to the body, they like to go ahead and put that, make them a legal thing. Synthetic drugs. The newer synthetic substances are abused have never been dubbed novel or new psychoactive substances. Many are manufactured in China and India and are created in home labs under less than sanitary conditions. That's the problem, is we're creating these things, these synthetic drugs, in a place where they're not clean environment. And it's not only that, but what else are they mixing with them? Mixing different types of chemicals has become the new normal in drug abuse. We, unfortunately, in the hill country here in Central Texas, methamphetamines are horrible drugs that have ran rampant over this area, and they're mixed and made with just about anything you can think of. It's crazy. These chemicals have on the brain have been known to make people homicidal and suicidal. Some have died accidentally because they believe the hallucinogens in their mind, the hallucinations in their mind. And this has happened. This has actually touched to some of my kids' friends and families, to where there's been issues where there was a circumstance where they had a kid who had done some drugs and ended up killing one of his buddies. They were having friends, over for that evening, but because the drugs that they were doing had caused these hallucinations, it created a snowball effect of things that took place that shouldn't have. And it was just the drugs that were involved that would have prevented it all. So drug laws. In 2012, 26 new substances were added to the list of Schedule 1 drugs. These are drugs that have no medicinal purpose at all. This includes 15 cannabinoid agents, K2 spice, and various other phenolphthaleins, which are found in bath salts. These things are the ones that make the patient crazy. These are the ones where it becomes a danger to you as a provider when you have to deal with these people, as well as danger to themselves. The hallucinations are so vivid to these people and so real, and they're under such restraint by them that they do things that they would not. It totally takes them out of their normal character. The law banned the chemicals used to make salts, isomers, and salts of isomers. So they've started to not only ban the chemicals, but the things that are used to make the chemicals themselves, because every month they would ban K2 and they would come out with they would just change the process of making it or add a different chemical to it, and it would change it up a little bit, and they could get it to pass where it was, they get it through to where it was a legal substance. So once they started changing up and banning the chemicals, that changed things a little bit for those drugs. Bath salts are one of the ones that kind of ran rampant, and actually it was, you get the people who are on the methamphetamine type highs like that, and it's hard to deal with. They're natural stimulants found in the fresh leaves and shoots of the cat plant grown in East Africa and Southwest Arabian Peninsula, Yemen, Somalia, Ethiopia, and Kenya. Around the Austin area, the bath salts went crazy. That and K2 and spice. All these things went crazy around the Austin area for a long time, to where they were having problems with kids on these things on a daily basis. They had overdoses on these drugs, and kids were dying off like crazy because of it. To the people of these regions, these drugs to them are no more dangerous than coffee or nicotine. They because they're not mixed with anything, they're used to them in their system. They're used to a level of that in their system when they deal with it. It's when you introduce that plus the other added chemicals to enhance it that our people over here, that when they get these in their system, it becomes a problem. Long-term use has associated health risks such as malnutrition, cardiovascular problems, gastric disorders, chronic and severe hemorrhoid problems, and esophagitis. These are all problems associated with bath salts. That these people use them to get high, and then they turn around and they create longer-term problems that they don't understand. The malnutrition is because of the fact they don't eat too much. It's an appetite suppressant. Cardiovascular problems, it speeds up the heart rate like crazy. And when your heart's running at 140, 150 beats a minute on a regular basis, it's not made to do that. Unless you're running from somebody, or you're doing something active, you should not be sitting there with your heart racing like that. So there's synthetic cathinone made its major appearance as an active ingredient in a deadly substance called bath salts, sold as a legal alternative to amphetamines, cocaine, and ecstasy, because the government didn't know what the effects of it were. As soon as it started getting it spread and they realized what it was, they were like, whoops, nope, that's illegal. Can't have you doing that. The chemicals elevate the dopamine levels up to 10 times more than cocaine. Cocaine is a bad drug. It's a very, it stimulates a lot of the mind, the heart. It speeds everything up. We're using this stuff, and it's increasing the dopamine levels in your system 10 times higher than that. You can see where the problems are with it. Bad trips cause paranoia, hallucinatory delirium, and death. That's the bad thing. And you can see the videos all day long on YouTube, people on bath salts. And we all sit back who are not on them, and we kind of, well, that guy's tripping out. It's kind of, to us, in a degree, it's kind of funny to watch how they react with them. But at the same point in time, this is a horrible epidemic of people using these drugs. What they're causing damage to their body, as well as the potential for us being in danger because of it while responding to these calls. Had family member of mine who has actually had smoked some K2, used the K2, and was completely out of character while we dealt with him. Never seen him like that before, and it was crazy to see the change, the 180-degree person that he was, and super strong, and trying to restrain him to keep him from injuring any of us was very difficult. Changes things. So our pre-hospital treatment for these is symptom driven. What do we do for it? Ensure that the scene is safe before approaching. These people, you need law enforcement on scene to help out with these. These psychotic behaviors and superhuman strengths are becoming common symptoms for these drugs, and they're pulling. I mean, these are the guys when you watch the video, they're getting tased by 6 or 7 tasers, and they're still walking around like it ain't even bothering them. I don't want that in the back of my ambulance in my 8x8 box. I'm gonna lock the doors. They can stay on the outside, and I'll come get them whenever they finally can restrain them. I don't want to be part of that. It's very important for you not to get tunnel vision. Make sure that you have a way out. Not all bizarre behavior is drug induced. Don't get the idea just because this looks like, they may be on that bath salts. It may not be that. Maybe they're hypoxic. Maybe there's another issue. Maybe their blood sugar is low as a reason why they're causing these issues. Obtain a history of current illnesses, and it may be difficult for these people because of the fact that they don't want to admit that they use the drug. It took a lot to get that family member of mine to tell me exactly what he used. I'm like, dude, this is not normal for you. I know you. What did you do? And it took a good 20 minutes, 30 minutes to finally get him to relax and talk to me to be able to tell me exactly what he did. And then he went straight back into craziness. It was insane. Dehydration and hyponatremia are common and should be treated with the use of IV fluids. So if you may need an ALS truck there to carry that guy to the hospital to get the IV fluids, unless you have the capability of starting an IV as well. So just keep that thing in mind. These just because they're on that drug doesn't mean you don't need to take care of them. These patients may require physical and chemical restraint. That would be another reason why I'd want my ALS truck there that can give them some of the benzos and things like that to kind of chemically restrain them and relax them to where you can deal with them. Physical restraints are good. The old way of putting a backboard and backboard sandwiching, don't do that. Tie their hands down. Make sure you do whatever you do. Make sure you're documenting your reason why, because that's most important, and keeping an eye on them and monitoring their vital signs when you're like that. If physical restraint is necessary, the patient should be restrained in a supine position. It should only be used until chemical restraint can be done. So if you have to use them for physical restraint, restrain them until they can get an ALS truck there. Then we can give them some narcotics or some benzos, and that'll kind of relax them to where we can get them to the hospital. We want to use benzos and ketamine. Those things work really well with restraint. Ketamine is super awesome. Just be careful because of the fact that if their hallucinations are bad, ketamine, they will get a bad K-trip, and they will do the same thing. It will just emphasize on some of those bad things, the bad hallucinations, and can make things worse. Benzos, you don't normally have that, and it normally puts them at rest, but it takes a large amount of benzos to get them that way. Rapid transport of these patients to local hospitals needs to happen. They need to be at the hospital so they can get taken care of. They can start doing getting additional medications. Not only that, but you got 2 people in an ambulance as well as a police crew, an engine crew. That's fine, but you still have 2 people in an ambulance. There's about 12 people at that hospital with 6 security guards that are ready to help you out. And they're there for a reason. More people at the hospital. Get them there quickly. So synthetic drugs that are out there, a lot of the ones we see are the bath salts. And they get abused. And as we see these things, they're up and coming drugs. Like I said, around Austin, Texas area, there was a huge epidemic where they went 6 months straight where they were almost on a daily basis. They had an overdose on spice or an overdose on K2. And it was a different kind of K2 every day because these guys were changing the formulas up for them. It was hard for them to keep up with it. Let's see. I'm going to throw real quick. We'll change the poll real quick. I know we're covered. This is a conclusion of this, but we'll leave it at this one. Let's see. How often are you coming in contact with these drugs on your public, on your groups of people? I will gladly say the only few that I've had contact with, they've been people. Unfortunately, they're people I know. Like I said, one of them's a family member. They're just different people who I know from the community. And we're a small town out in the middle of nowhere. If it's come to us, then its waveform is in the inner city and it is a problem. The number of instances EMS providers comes in contact with a patient that is under the influences will continue to increase. We will have more and more of these calls as they continue to go. Even after the laws were formed, these chemicals were made from are continually being changed and into new substances. These are some of the brightest chemists in the whole world because of the fact that they continue to change these drugs pretty rapidly too, and get them out there pretty quickly. So it looks like most everybody most people, 5 of you haven't had any calls with them yet. All right. Well, some of y'all are the ones who are industrial setting, only work part-time, things like that. And then some of you see them once a month, but you do see that, we will see them more and more as we deal with it. And they're going to be more and more mainstream. Yes. All right, so seizures. We've got probably about another 10 minutes. We'll run over seizures real quick. See if we can hit all these slides and then get you out of here and get you into your test. Got probably about 7 or 8 slides to do here. So our objectives are to list the incidence, morbidity, and mortality of seizures across all ages. Describe the pathophysiology of a seizure. Identify the various classifications of seizures. And list the appropriate steps in treating the seizure patient on a basic level for sure. Seizures. The definition of seizures is an isolated episode of neurological dysfunction resulting with abnormal activities causing a sudden change in behavior, sensory perception, or motor activity. All of a sudden your brain says, here's a whole bunch of senses, let's make your body do this. That's pretty much what happens. The seizures can manifest with many different presentations depending on where they start or originate in the brain. They have many causes. They're provoked by acute medical conditions such as trauma or fever, as well as they can be something that is non-provoked or unprovoked that are due to normal medical conditions considered epilepsy, when you have 2 or more of those. I have a nephew who as an infant was diagnosed with seizures and has since grew out of those seizures, hadn't had a seizure in forever it seems, but he had a history of it. You have the infants who have the fever, all of a sudden their fever spikes or increases and they go into having a febrile seizure. It just depends. So our incidences are epilepsy is one of the most common neurological conditions with approximately 5% of the population having seizures. We run calls on these people on a regular basis. Sometimes they don't want to go to the hospital because they're so used to having them. They know how to treat themselves, or the family knows how to treat them. They just want somebody there just in case. The immature brains of the infant has less inhibitory input and therefore has a lower threshold for seizures. It's why while a baby may have seizures, as they get older, they're able to take those sensory inputs and they don't affect them near as much as they're an adult. But as a kid, their ability to deal with that is there. 25% of children who experience an unprovoked seizure will not have any further seizures in childhood or adulthood. That's febrile seizures, where their temperature, you don't get too many adults that have febrile seizures. Most of those are reserved for infants or children. Then you have the childhood seizures. Because their brain is so susceptible to the electrical impulses compared to an adult, you have a seizure activity that takes place with kids, more likely than in adults. So the morbidity and mortality of a seizure. Several epidemiologies, hate that word, huge. Epidemiology studies have attempted to measure the impact of epilepsy on a person's life. At the age of 33, 55% of the participants reported having no seizures and there was no longer being monitored for epilepsy. So that's from birth to 33 years old. After 48% of those reported still having epilepsy and 42 were registered for services for the disability. So we see how 42% of these people become disabled because the epilepsy is so prevalent in their life, it makes them change their way of life. Their inability to do our normal everyday functions. 60% had a driver's license, and 65% felt that their epilepsy had a significant impact on employment. These are the ones, and we run these calls on a regular basis to where you get called to a place where a guy's having a seizure, and you get there and they're like, he has a history of seizures. And you talk to them after they start coming out of it, like, man, I normally have seizures. I'm just going to go home and rest for the rest of the day. Happened to me at multiple places, on multiple calls, multiple different avenues and different types of people. It happens. They're there. So the pathophysiology of genetic seizures is there are two main causes: genetically predetermined and acquired. Genetic seizures are generally generated by ion channels malfunctions that are responsible for initiating intense activity in neurons, resulting in the rapid spreading of this abnormal intense electrical activity. So excuse me. The electrical activity takes place and creates basically a blanket of electricity that creates and hits all these neurons and causes all this to take place. With that, it changes the way things are going in your brain. It exceeds the inhibit actions of the cortex, and general seizures will result because of that electrical activity. Starts in one place, spreads throughout the brain, runs through the body, and basically tells all the functions of the body to start moving. The cortex of the brain is the greatest risk for infection and trauma. And injury to the cortex results in a reduction of the inhibitory force, and subsequently the delicate balance is disrupted. So basically your brain has electrical activity that runs over it all the time. It's always thinking, it's always moving. Certain areas are able to let things go, and certain areas are the ones that get triggered. When you lose that ability to let things go, and every little electrical impulse changes or excites the neurons, then you start to have the problems with the seizures. Children younger than 5 years of age have a greater than 9% chance of having a post-traumatic seizure following head trauma. Why is that? Anybody guess? Because that threshold is lower in the child. Let's see. Developing brains, yep. That threshold is lower in a child than it is in an adult. With that trauma is going to create damage to that threshold in the developing brain and things like that. So it's going to allow that ability for that electrical impulse to make bigger impact on things it shouldn't. The incidence in individuals between 45 and 65 is only 1.5% of having a seizure, an injury seizure. So a lot of times you're not going to have, when you're dealing with the elderly that's fallen and hit their head, they may not have a great as a risk of having a seizure as you will as a kid who has fallen off the bed and hit their head. That kid is more likely to have a seizure than what an elderly person is. So we should treat that and prepare ourselves as we see this kid who's fallen off the bed. All kids fall off their beds and hit their head somehow, some way. Everybody's run that call. They get the big goose egg. Well, then this kid has a seizure, and that's usually when the parents call us, is when they've had this seizure after a fall. Part of the process of the body and everything that's involved with it, we turn around and take this person and take care of them from that point in time. So we have partial focal seizures. Each region of the gray matter is responsible for a highly specific function. The manifestation of a partial seizure is related to a focal area of the brain involved. So basically, if I have this part of my head is telling this part of my hand to move, and then all of a sudden I have a seizure on this part, this hand is going to start moving all like crazy. That basically is the correlation between the two. The function responsible of the region involved in a seizure will be interrupted during a seizure. Does that make sense? You will not be able to use that, or you have problems with that, or that's where your problem is that one specific area. Each area of the motor cortex represents an area of the body. When a seizure takes place in that area, it causes the muscle groups to react. Just like what I've said. It's pinpoint to that certain area of the brain when it's this arm, your left arm, your right arm, depending on what it is. So generalized seizures. There's secondarily generalized seizures. Sorry about the misspelled word there. Good night. Partial seizures start in one area, then spreads to a larger area due to abnormal electrical activity. It starts in once the electricity impulses start from the top of the head and work their way down, say that. And it covers the rest of their body, creating that seizure. Now, if it's a primary generalized seizure, it starts in the thalamus with an abnormal generator and causes electrical activity in all areas. So it can start from one area and move out, or it can start primarily, the primary general seizure will start from the thalamus and move from the inside out. It represents 30% of all epileptic type seizures, a general seizure does. That is basically movement of all parts of the body, arms, limb, everything will be moving. So how do we manage a seizure? How do we evaluate it? With supportive care is the first steps in approaching a patient. The greatest concern is the fact that we want to make sure that they're safe, they're taken care of. We want to make sure that they're turned on their side, they're open, have an open airway, and that they don't block off their own airway. Want to make sure that they're not hypoglycemia is not there. That may not be that's not the cause of the seizures. Checking a blood glucose level. That's important on these patients. There's a lot of home medications that are to be taken for these patients who have seizures on a regular basis. They usually take these anti-epileptic drugs, phenobarbital, primidone, dilantin, and tegretol. Those are names that as you're transporting patients and you see patients who have that, you can ask them, do you have a seizure history? Yep, that's why I take that. It's one thing as a basic I learned, or as an EMT, doing transports, was medication list for patients. Really gotten a lot of work in doing that, so I learned a lot of these. Some prescribed seizure medications as well as Depakote, Lamictal, gabapentin, and Keppra. Those they work differently on different parts of the brain. They are used to treating primarily, depends on the seizure is what they get prescribed. Like Lamictal is used for treating partial seizures, or it can be added to one of the others, and it helps out for just the generalized seizures. Gabapentin is used for multiple things, partial seizures as well as secondary generalized seizures. It just depends on the seizure that they're having. There's got to be a different treatment for them. So seizure treatments, if a patient is still actively seizing, they should be rolled to their side to prevent aspiration of saliva. Don't want the tongue in the back of the throat. Do not place anything in their mouth. There is no evidence that the tongue will obstruct their breathing, especially if you put them on their side. That's a position of recovery. That's where we want them. To prevent injuries, cushion the head because of the moving and jerking. We don't want any of that to hit. You don't want them hitting their head multiple times on the ground. Tighten any loose garments around the neck, things like that, because as they stretch and they're stretching this out, they could be occluding their own airway. Not only that, but their own jugular veins because of the fact that they have a necktie on and it's super tight. Document the length of the seizure, the type of movements, head or eye turning, the time required to return to alertness and full consciousness. These are good, important information that's got to be passed on to the hospital. When you give your report, put those things in there. That way they know how long the seizure lasts, what happened, how long were they postictal, or in recovery, basically. So we ask about the events leading up to seizure. Was there anything that they seen? Did they get an aura beforehand? Is there anything else that happened? Did they fall and hit their head, or were they laying on the ground initially and then it started the seizure? Those things are important to know. Is there trauma related secondary to the seizure? If the patient experienced head trauma immediately before the seizure occurred, suspect of a hemorrhagic brain problem where there's blood in the brain. If they fell, hit their head, then has seizure, there's a chance that they could have a brain bleed. Let's see. Got one more poll I think I want to throw up that I worked on today. I got to get them all out there. I want to know what everybody's current treatment for seizures that's in your protocol. For my protocol, of course, we run ALS trucks. Rarely ever do we have a BLS truck that's, at all. So we always use our medications. We are a huge user of the benzos for those. Treatment: do not attempt to restrain the patient. Let them seize till they they stop seizing. Keep track of your time. If you have the use of medications, diazepam rectal gel is used. A lot of times parents, if they have kids who have seizures, will have that, and they will already have given it and administered it before you get there because they know how. And it works well. These patients still, if the parents will allow you, still need to be transported if possible, because the chances are that they need to get their levels, their medication levels checked, things like that. Last slide here, and then we'll let you go take your test. I'm trying to keep it too long. The patient has an implanted vagus nerve stimulator. Suggests the family member use the magnet to activate the VNS. I've only dealt with those a couple times, and the people who were the caregivers there were able to use the VNS before we ever got there. Super easy. Once they touch the skin with it and they turn it a certain way, it creates this simulation where it stops the seizure. It's crazy. Let's see, reattempts up to 3 times total. Assist if it does not interfere with other care. So basically, you can use that VNS up to 3 times. If it doesn't work, transport this person to hospital, get ALS care. You can use they will still be able to use the benzos on these patients if you can get an IV on them, things like that. The VNS things, like I said, I've only seen them a couple times, and they were usually used before we ever arrived on scene. And they were told us, but these patients, even if you take them to the hospital and they are just normally sick, they will have that. They'll want to take that magnet with them. They take it with them. They have it with them at all times, no matter where they go, just in case they have a seizure. So we're coming to the end. Seizures affect a large population across all ages, and roughly 40% will experience multiple seizures. They're going to be a percentage of our calls that we're going to see. We may not transport them because they don't want to be transported because they've already been to the hospital, they've already been evaluated. I've seen my neurologist on a regular basis. I just have seizures. So they're there. The area of the brain's being affected. I'll answer your question. Let me finish this one slide, Greg, and I'll answer your question on the VNS things. The area affected by the abnormal activity will result in a seizure-like activity. So the area of the brain that's affected by the electrical current is what's going to cause that seizure. And that's how they go in and pinpoint which area of the brain has caused the problem, is they do a graph basically, and they map the brain and are able to tell which area is affected. Patients with a history of seizures are prescribed medications and that help to limit the number of seizures, but they still potentially can have seizures. That they're just because they're on the medications, those have to reach a therapeutic level. If they're not on the therapeutic level, is not up to game, then they will have a seizure. And then those patients usually have to go in, have labs drawn, and get back up to square one. Sometimes these patients may stop their medications on their own, thinking they'll be just fine. For one reason or another, and they drop below that therapeutic level and will have a seizure and end up back in the hospital. As a treatment, we want supportive care. Make sure that we protect them and keep them safe. Do not let them splash around. Do not restrain them by any means. Make sure we keep them on our side just to protect their airway. And with that, sorry I ran just a little bit longer than what we normally do. I'm still within that 2-hour time limit. Give you the ability to go take your test real quick. It's a 15-question test. You're free to leave the class at this time. If you have questions, I'm going to answer Greg's question here in the box. If you have any more input, my email is right down there in the bottom. Send me an email if you like the class, if you don't like the class. If there's something you wanted to, look at that, somebody's taking the Patriots. That's not even nice. I don't like the Patriots at all. I don't know why. I never have. But other than that, that's about it for this class. Greg, on the VNS things, they're not as new as what, they're several years old on those. Thank everybody for attending. I do appreciate that. They're not as new, but they're more and more prevalent. They're being put in